All right, so let's get into it with a discussion on mood disorders. When we think about mood disorders, you're thinking about unipolar and bipolar mood disorders. So if I were to ask you, what do you think I mean by unipolar mood disorders? Does anyone have a thought as to what I probably mean? All right. Ahmed, what do you think I mean when I say unipolar? Norhan?
Um,
Norhan first. Go ahead.
right. So considering that bipolar has two extremes, I would assume that unipolar has just one of those extremes.
That's right. So when we talk about unipolar mood disorders, we're really talking about major depressive disorder and some of the derivatives, right? So whether we're talking about major depressive disorder of a single episode, whether we're talking about major depressive disorder, recurrent subtype, whether we're talking about uh, persistent depressive disorder, which used to be referred to as dysthymia, um, whether we're talking about uh, PMDD, premenstrual dysphoric disorder. These are the conditions that are in the unipolar mood disorder family. When we talk about bipolar disorder, we're talking about there are two extremes. In order to have unipolar depression, you cannot have any manic states. But when we talk about bipolar disorder, we're talking about bipolar 1, we're talking about bipolar 2, we're talking about a single manic episode, we're talking about cyclothymia, right? So the mood disorder family is quite broad. Um, any thoughts or reactions to that? All right. Well, thank you. So let's get into it. All right. So, mood disorders. A mood disorder, also referred to as an affective disorder, uh, refers to some kind of disturbance in mood. And we tend to see children with mood disorders show some form of an extreme or a persistent or poorly regulated emotional state. Now, even though we refer to mood disorders as an affective disorder, the affect, as you may recall from other lectures, is the outward expression of emotion, whereas mood is the internal emotion or feeling, right? So I do want to make that distinction between mood and affect. So in the past, we used to believe that depression did not exist in children the same way that it shows with adults. Now, obviously, we know that's not true. We know that children do experience depression, but oftentimes it's overlooked or misunderstood for other diagnoses. And you may recall in another lecture, we talked about screening for oppositional defiant disorder, ADHD, and some of those conditions show similar features to mood disorders. So we have to be very careful as to making sure that we're diagnosing properly. And now with social media, what is really interesting related to mood is the rates of depression in girls between, I think it's about 10 years old to 16 years old, has increased considerably. And the rates of death by suicide in this group also has increased. So our previous belief that depression doesn't manifest in children, obviously we know it's incorrect today. So it is one of the most debilitating childhood-based disorders. We know that. In fact, the two most common conditions that people will face are anxiety and mood disorders. Now, what makes depression so debilitating?
Hello.
So,
Hey,
uh,
Professor, this is Gianna. I was trying to tell you that I'm here, but my audio was not working.
okay, thank you for letting me know.
Appreciate it.
All right. So, what makes depression one of the most debilitating childhood disorders? What do you think, Savannah?
Well, there's a lot of social and emotional development that has to happen when you're a child. And I think if you're experiencing that depression as a child, it's probably less likely you will get those life experiences, or if you have them, that it's incredibly difficult for you to engage in the first place.
Right. So when a person is depressed and they're trying to establish relationships, that depression could interfere with building friendships and romantic relationships. That's true. How about academically? Any thoughts about the academic
Mm.
impact?
I think, I mean, if some people, like, I know in depression, people sometimes don't even want to get out of bed. So if they're not getting out of bed, they're probably not going to class and they're not learning. So obviously they're going to do pretty poorly.
Sure. Right. One of the features of depression is not just over like changes in sleep patterns, but the energy to get out of bed. So absent absences are higher amongst people with depression. Truancy is higher amongst people with depression. And let's just say they even make it into the classroom. We know that there are some cognitive features of depression, such as uh, concentration, right? Motivation. We know that there's more distractibility, and that results in poor performance in classrooms. So we know how strong this condition can be and how it can impact people in the classroom. All right. Now, the rates of mood disorders are increasing. The diagnosis, the age of onset is decreasing. I think part of this is better detection, and I think part of it is reduced stigma around mental illness. But I also think that we live very differently today. Social media, for all the good that it brings, I think that it brings a lot of problems as well. I think that there's a lot of social comparison. Oh, my friend seems to be having such a happy life. They're always doing this. They have all these opportunities and I don't. Or even cyberbullying, right? Cyberbullying is another issue that could be linked to depression. So it used to be if you had a bully, all you had to do is, run faster than them. And once you got home, you didn't have to deal with them until the next day. And when we talk about social media, someone can troll you 24/7. Someone can really make it difficult. So sure, the age of onset is certainly decreasing. Now, how we experience or the symptoms of depression is going to also change with age, right? That makes sense as well. I think one of your peers mentioned how the social and emotional piece plays a role. Um, Teenagers with depression, there are going to be a lot more of those social withdrawal, a lot more of social alienation, feeling like one doesn't fit in, uh, something that looks different than pre-puberty or pre-adolescence. All right. Now, under the age of 7, most of the time we don't detect it. It's kind of it hides in other conditions. So it's very hard to detect it under the age of 7. Not that it doesn't occur, not that it's impossible, but it's certainly harder to identify. So let's talk about the diagnosis major depressive disorder. Now, major depressive disorder can be a single episode where this is the first time a person has experienced this, or major depressive disorder can be recurring, which means that they've had to have at least one major depressive episode prior to the current. Now, here are some symptoms, and you don't need all of them. You need about 5 of these symptoms. And if I'm going to give you a time frame for major depressive disorder, to be major depressive disorder, you have to have these symptoms for most days, if not all days, for at least 2 weeks. So major depressive disorder, an episode has to last 2 weeks in order for you to even meet the criteria. So that's the time frame. Now, when we talk about symptomology, we see depressed mood and sadness, right? So the idea of feeling sad, every single one of us might go through periods of sadness, or something might happen and that day we're a little bit bummed out. But that's not depression. Depression has to be more persistent. It has to be for 2 weeks straight, right? Most of us can regulate our moods pretty much that day, if not by the next day we hit the reset button. So when you have depressed mood ongoing for 2 weeks straight, that's of concern. Another term that is important, something called anhedonia. Anhedonia is the decreased interest in pleasure. So you might have heard the word hedonism, right? Or hedonistic, which is pleasure, right? So anhedonia is a decreased amount of pleasure. And some people have such a decrease in pleasure that they lose the ability to derive any pleasure altogether, right, during a depressive state. There might be changes in weight and appetite. Now, notice the word changes in weight and appetite. Not everybody who's depressed gains weight. I know you might see in the movies, there is a portrayal of someone who's depressed and all of a sudden they're eating like junk food or ice cream or whatever, which long term would result in increased weight. But if there is a marked increase or marked decrease in weight, that is a flag, right? So it does. Some people who are depressed can't eat; they lose their appetite. And I'll give you an example where some people report it more commonly. If a person loses a loved one and they're so grief-stricken, they may lose their appetite, right? So depression operates similar to that sometimes. We also see sleep disturbances. Now, sleep disturbances, once again, you can have a person who has a shift where they're sleeping significantly more than usual or significantly less than usual. The recommended amount of sleep is anywhere between 7 to 8 hours. And, with the developing brain, it can be upward of 10 hours in children. But that being said, let's imagine we had a person who slept 6 hours and their routine was they slept 6 hours a night. And then all of a sudden that person went from 6 hours to 4 hours or for 8 hours and so forth, right? So if you see a shift that's significant, then there's probably something going on disturbing their sleep, right? So a sharp increase or a sharp decrease in sleep could signify some form of depression. Now, I got a direct message. Francesca, no problem. I'll get you on the other side. All right. Other sleep disturbances might be having difficulty falling asleep, right? Some people with depression can't get to sleep. And you might hear the recommendation, oh, take melatonin or whatever. And that makes sense to some degree because melatonin and serotonin are biochemically similar. So it makes sense and it does help with sleep. But that's just masking a bigger problem. We need to figure out why you're struggling falling asleep, right? It could be depression, could be a whole host of other things. Other people with sleep disturbances, they have what's called intermittent sleep, which means that they fall asleep, but they can't stay asleep. They wake up or it's kind of disturbed. And I have a client now that I'm working with, and she has the Apple Watch, and she can track the amount of deep sleep she gets. So, and the amount of time she wakes up. So, one of the things that we've noticed with her depression was that she might wake up 5 times in the middle of the night. And she's like, I don't even remember waking up these 5 times. I'm like, well, you probably did, but it was just, so quick. You might have been up for 5 minutes or whatever, that it was disturbed. And then the other data point is the deep sleep. She's getting 15 minutes or less of deep sleep in a whole night. And I'm like, okay, we know something's going on here. So that's pretty cool that we can use your basic wearables for, biofeedback as a measure of here, this is what's going on. Now, we also see psychomotor retardation. Now, retardation means to slow down. So a person physically may look like they're dragging. They might walk slowly. They may feel like they're carrying a boulder on their shoulders. So they drag. When we refer to psychomotor retardation, that's dragging. It's hard to get out of bed. The weight of the covers are so heavy that you can't lift them off of your body, right? That kind of like dragging. Or agitation. Some people become more irritable when they're depressed. We also have fatigue. Fatigue is a very big issue with depression. Some people have fatigue or a loss of energy. People feel hopeless and helpless and worthless, right? We also have difficulty thinking and concentrating. I think we talked about that and how that could impact studying. And then there might be thoughts of death and suicide, right? So these are a broad panel of the symptoms one can manifest. And as I said, you don't need all of them. You only need 5 of them. Nurhan.
I recently had a conversation with a few of my friends
Sure.
about how they believed that depression and like most mental disorders weren't real, in the sense that they can be treated through therapy. Like anything that can be treated through therapy wasn't real, and anything that required medication was. So I use depression as an example, and ADHD and panic.
Yeah.
And, like my question is, how do I explain it to them that just because it's not a physical, seeable disability, that it doesn't mean it's not real?
So I would go about it another way. If you have a kid with low muscle tone, is that a disorder?
Well, yeah, their argument is anything physical that they can see is a disorder. But
Now,
still,
now hang on. The argument was the use of medication, right? So it's either it requires medication or some kind of physical manifestation. Is that what they're saying? Okay.
but autism.
Yeah. Go ahead. I'm sorry. I didn't want to speak over you.
I said autism is the exception. I'm not sure why, but yeah.
Well, invisible disabilities are still disabilities, right? So they recognize autism as a mental disorder.
Yes.
Okay. So your example of depression is a good one, right? Because it's actually fairly common, in fact. So the idea that someone is struggling and, they look on the outside like there's nothing wrong, it's a good example. And I like it as an example because with depression, we're not jumping straight to medication. We do use medication when appropriate, right? And in fact, my argument back would be that in many of the mental disorders, you could use medication. The difference is that psychologists want to focus on behavioral interventions or cognitive interventions before we jump to medication. So, sure, we can do a more invasive treatment if that's the way, if that's the only way you're going to acknowledge it as a mental disorder. But it shouldn't be that way, right? Similar to many other conditions, um, they work beneath the surface. So, would that person consider something like high blood pressure like hypertension a disorder? Well, you can't look at a person and say, "Yep, that person has high blood pressure." And if the answer is yes, then there are conditions that are happening beneath the surface. Same thing with diabetes, right? Now, obviously, we have ways to measure these things, right? So we've created physical tools, whether it be a blood draw, whatever. Atherosclerosis, right? So the thickening or hardening of the arteries, which is a precursor to heart problems or heart failure. Would they consider that a condition? You can't see the plaque on the arteries, right? Most people are not doing sonograms, right? Uh, so the argument that if you can't see it, it doesn't exist as a disorder is a silly one, right? So I would have went the other way. Instead of using depression, which is a good example, as a disorder, I would have used other medical conditions that are not visible to the naked eye as an argument.
I
Right?
mean,
Yeah.
yeah.
Go ahead. I'm sorry. Go ahead.
But they also use cancer as an example.
Oh,
Their argument was because it requires medication and lifelong treatment that like it is an actual disability rather than depression, which can be treated through just therapy.
so if a condition can be treated and it's short term and it isn't treated with medication, it's not a disorder.
According to
According to them, the whole field of physical therapy should be thrown out.
thank you.
Occupational therapy should be thrown out. The logic doesn't make sense.
Yes.
By the way, I want to open it up to other people, right? I appreciate that we're having a discussion, but this is a big issue when it comes to mental health is people want to discount the impact of mental health because it's not visible to the naked eye. So let's see, I see something going on in the chat. Okay, so a person said they're acknowledging that depression needs to be treated in the first place, proving that it's a disorder. That's a good argument. I like that. So if it wasn't a problem, why does it need treatment? If it wasn't a disorder, why does it need treatment? Right. So I think that's a good point as well. Thank you, Savannah. Any other thoughts? Right. And then I'll tell you a larger take-home message of what's really going on.
To kind of piggyback off your hypertension argument, they
Mhm.
don't necessarily use medication to lower blood pressure. They'll use, gotta go lose some weight, gotta go exercise, that sort of thing. So it doesn't necessarily take medication, but it's still a disease or disorder.
And it doesn't have to be long-term, lifelong.
Yes.
So that's why you have to, because if a person, and I'll tell you what's really going on, and then I'll bring it back to Sophie. What's really going on is that there's a mental health stigma, and people don't treat mental illness or psychological disorders the same way as over physical disorders. And there is a stigma attached to mental illness. So the whole reason why I went the opposite route of trying to say, okay, well, this condition, if you use a psychological disorder as your counter argument, they might say that one's a disorder, but this one isn't, right? So, okay, we'll give you these 10 to 12 conditions, but the rest of them are not. So the better way of approaching is to attack them from their point of acknowledgement. You acknowledge hypertension is a disorder. Do they acknowledge that obesity is a disorder, right? Obesity is another one that doesn't have to be long-term. It's in the ICD. It is a diagnosis. And if they could acknowledge that there is an issue with an obesity epidemic and it's diagnosable as a disability, then you don't have to treat obesity with medication. I know some people are using diabetes medication like Ozempic today, but you don't have to do it that way. You can treat obesity with dietary changes, exercise, and obesity doesn't have to be a long-term chronic condition either. So when you target physical conditions that they would say, yeah, this is a disorder, then you have a better argument with them. So I would go the physical route. The whole field of PT and OT would be gone by their arguments. Anyway, so yeah, so let us continue. So in terms of the prevalence rate of depression, it's anywhere between 2 to 8% in children between 4 and 18, right? So that's the rates across childhood. Now you'll notice that I said earlier in the lesson that it's hard to detect depression before the age of 7. Doesn't mean it's impossible. So you see that range. And in terms of depression, we know it increases with age. So the younger you are, the less likely you are to get the diagnosis. As you progress to school age and then adolescence, it increases even more. Co-occurring diagnoses, common conditions, anxiety is a common one. In fact, I probably have said this maybe a half dozen times throughout the semester. Anxiety and depression are cousins, right? They share neurotransmitters. They share the hypothalamic pituitary adrenal axis, the HPA axis, and so forth, which makes it likely to have a co-occurring diagnosis of anxiety. Dysthymia. dysthymia, which is now referred to as persistent depressive disorder, is a long-term or chronic depression. It has to last for a minimum of 2 years without any breaks of 2 months or longer. Now, what's interesting about dysthymia is you don't need those 5 features from the previous slide. You only need 2 symptoms. So it's long-term, low-grade depression. So you might say, well, how is it possible to have persistent depressive disorder and major depressive disorder together? You can actually have both major depressive disorder and persistent depressive disorder, because which we refer to as double depression, by the way, because you can have periods that are more extreme than others. So when you hear dysthymia, think persistent depressive disorder. In the chat, I see someone said, I know that you stated that interrupted sleep can be a sign of depression, especially if they're not getting enough REM sleep, but could it be sleep apnea, especially in pediatrics? Sure, 100%. It does not have to be depression. And in fact, if you are a good clinician, you might recommend a sleep study, right? So that you can rule out things like sleep apnea. Because in order to diagnose a mental health condition, you have to rule out other explanations. It cannot be better explained by sleep apnea or something like that. 100%. Okay, so other issues: conduct disorder, oppositional defiant disorder, ADHD, and substance use disorder are co-occurring conditions. Now, interesting, the substance use disorder is a pretty interesting one, because what we see is the substance use disorder. It's a disorder in its own right, but it could also be used to mask the feelings of depression or to mask the feelings of anxiety. So substance abuse could be a symptom of another disorder, or if it is long-term enough, it can be its own condition. All right. So let's talk about it. The usual course, the age of onset, is typically 13 to 15 years old, right? And the average episode lasts for about 8 months. So a person who is struggling with depression in childhood, it doesn't just magically go away, right? It requires effort. It requires therapy more often than not. And even though the criteria to reach a diagnosis is only 2 weeks, you're seeing these children or early teenagers are struggling with depression. It could be a whole school year that they're struggling with depression, right? And ultimately, we do see with therapy, the vast majority of people do recover. However, we do see the reemergence of depression at a later point in time. If you have one depressive episode, it predisposes you for subsequent depressive episodes. So we do see reoccurrences of depression. And even after recovery, we see some potential physical or health-related issues like higher stress levels, other health problems, and so forth. Now, pre-puberty, there are no gender differences. After puberty, the ratio of depression goes to about 2 to 1 and sometimes 3 to 1, right? With in higher rates amongst females. Now, that should not shock you. It still conforms to the pattern that mood and affective disorders are oftentimes more common amongst females. but you can see it becomes more prevalent and the difference becomes greater throughout the lifespan, making women more predisposed. So if we were to look at a graphic following 10 years, you see the rates of depression at 11 are roughly even, 13 are roughly even. By 15, now we're assuming most people are post-pubertal by 15, right? The average age of the first menses is about 12 years, but it can range between 8 to 16. But 15 is on the upper limit. So we're assuming the vast majority of girls have hit puberty by 15, and all of a sudden you see a shift, right? You see that girls tend to have higher rates. In this graph, girls are reflected as blue. Boys are reflected as gray. And then obviously following them, 18 and 21, the gap does not close. So it's a really interesting study. It's one of those classic studies that was done, and I don't think you can find a developmental or childhood psychopathology textbook that doesn't cite this study. So it's a pretty robust finding. All right, so now dysthymic disorder. Now, here's the deal. When it comes to dysthymia, in the DSM-5, we're looking at 2 years, not 1 year, so that needs to be updated, right? And dysthymic disorder or persistent depressive disorder, it's less severe but more chronic. You might remember I said with dysthymic disorder, it's persistent. It is low-grade chronic depression, right? So in terms of dysthymic disorder or persistent depressive disorder, as it's referred to today, you don't see as much of the anhedonia. That's a more extreme level of depression. We don't see as much of the social withdrawal or concentration or thoughts of suicide and physical complaints and so forth. So the point I'm trying to make with this second bullet point is that persistent depressive disorder or dysthymia, it's less intensity. And I'm going to share a story with you shortly. Now, I said you can have double depression, which is if you have periods of major depressive disorder alongside that 2-year mark, you can have what's called double depression. All right. So I'll share with you a story, and it's not a story about childhood mental illness, but it is an issue of dysthymia. So I was treating a client. Actually, the client was transferred to me from another clinician, and that clinician went out for 3 months on maternity leave, and they had a health insurance which required authorization of services, and you had to apply for a number of services at a period of time, and then you had to submit another authorization, or what's called an OTR. So the client ran out of sessions in the midst of me covering them, and I had to fill out this OTR, which was to request more services. So I did, and I submitted it to their insurance carrier, and we got a letter saying that they were not going to approve any further services, which was peculiar, at least to me, based on the person's diagnosis. Now, this person had been at the Hamilton Madison House for maybe 9 years, something like that. And so they were a long-term client. And in terms of the diagnosis, they had dysthymic disorder or what we now call persistent depressive disorder. Fine. So I saw on the form, it said two things, two reasons for rejection: suboptimal care and suboptimal medication management. Now, I just got the client, so I didn't take it personally that they said, oh, they're receiving suboptimal care. So what they were arguing, because I picked up the phone and called the insurance carriers, how do you have a client in treatment for 9 years? And my response to them is, well, the diagnosis is dysthymia or persistent depressive disorder. This is by definition, this is a person who is going to struggle with symptoms of depression for a long period of time. We don't expect their symptoms necessarily to magically go away. So when you're in treatment, you're helping them cope with the day-to-day. So they have long-term or chronic depression, but it's low levels of severity. So their diagnosis in of itself should have told you that they're going to be in treatment for a long period of time. And then I asked about the medication. I said, okay, well, what's the problem with the medication? I'm not the prescriber, but I can speak to our medical director. And they said, well, the person seems to be on half the effective dose of another person. And could it be that they're not receiving sufficient medication? And that's why they're not making any gains. And I said, listen, I'm just a psychologist. I can't answer that, but if I can put you on hold, I will speak to our medical director and I'll tell you exactly what's going on. And I was, again, at the Hamilton Madison House. I was just an intern, so I didn't know what I know today. But I went to Dr. Chen and I said, Dr. Chen, such and such insurance carrier is saying such and such client shouldn't get services because you're not prescribing a high enough dose. And he said, well, did you tell the insurance company that she's Chinese American and that oftentimes Asian Americans tend to have lower effective dose than their Caucasian counterparts? And I said, well, first of all, I didn't know that, but I'm glad you taught me that. And I went back and I said, listen, we're dealing with a Chinese American female, and it is not uncommon for them, for Asian Americans to respond to lower doses. And they were very upset because I guess I pinned them down on both of their reasons for disqualification. And so ultimately they gave in. They're like, fine, we'll give you 10 more sessions, but we want an updated medical in the next 2 sessions or by the next 2 sessions, to which I said, no problem, that's fine. But they were a little salty because, you know, the insurance companies don't necessarily always want to approve services. They're in a business of saving money. So this was a bad experience for me with this particular insurance company, but it was a very valuable lesson. It was a valuable lesson because there are 2 principles here. One, when we're dealing with dysthymia or persistent depressive disorder, the person is going to be in your office, that they are going to be receiving services for a longer period of time than one might expect. So that was the first lesson. And then this was my first true exposure to ethnic differences in pharmacology, and learning that just because a textbook says a dose should be, let's say, 20 milligrams of Lexapro, Well, you might have people prescribed 10 milligrams because their body's going to metabolize it differently. So those were two really cool lessons I learned. But in any event, that's my story that I wanted to share. Okay, so in terms of dysthymia or persistent depressive disorder, and you'll notice I keep using both languages because I want you to know that DSM-5 has moved to the language of persistent depressive disorder. But if you open up the ICD 11, it still has dysthymic disorder. So I keep using both of the languages, but it's very low. It's the comorbidity of having this long-term depression in children is significantly low, right? And if they are going to have a diagnosis, the most common comorbid diagnosis is major depressive disorder. All right. So if we're to look at the developmental course for dysthymic disorder, typically the age of onset is 11 or 12, which if you're keeping score is earlier than major depressive disorder. Some people suggest that it's a precursor for major depressive disorder. And when you think about it, that logically makes sense, right? Because if you need fewer number of symptoms to meet the criteria of dysthymic disorder, you know, it could be that through time, the number of symptoms or features starts to increase. Now, the average episode for dysthymia is anywhere between 2 to 5 years. Most people do indeed recover, but there is a higher risk for other disorders like major depressive disorder, anxiety disorder, and conduct problems. Okay. So if we were to look at unipolar mood disorders, we know that it affects many aspects of this child and adolescent's life. So the biggest thing that you're going to see is the child's academic performance is going to decrease. So you might have a student who is an A student and all of a sudden they're performing at a C level, and the drop off is not better explained by some kind of learning gap. You might wonder, well, why did their performance drop off to a C level? Well, there might be less motivation to do their work. There might be just, it feels like heavy to do their work. So this happens regardless of intellectual ability. So we're not talking about a person who has some form of an intellectual deficit. We're talking about a person who's, in terms of intelligence, within a normal range, and yet they're still performing poorly. Now, some cognitive distortions we might see feelings of worthlessness, feeling like a failure, being overly critical, can have rumination or recurring depressive thoughts. There can be pessimism or negative mindsets, hopelessness. We see low self-esteem, suicidal ideations. All of these things tend to manifest on a cognitive level. Socially, which some of you mentioned, we see fewer friendships, feeling isolated or lonely. Now, I always emphasize the difference between social and emotional isolation or loneliness. A social isolation legitimately means that there are few people that you can identify as friends. An emotional isolation, you could have 1,000 people in your friend group. You just don't feel close to them, right? So there is this feelings of loneliness, isolation. There's withdrawal, poor coping. There tends to be problems with parents as well, siblings as well. These tend to be flags. So how do we explain depression? There are different. there are different theories of
Oh,
depression.
yesterday I witnessed two kids.
Your
right
mi-
across
your
from
mic
the
is
door.
hot.
Do you
If
remember
you
the
mute your
PTR?
mic.
Okay, it was woman shoes, and right in the front they have the L's.
I had to mute them. So, all right. So I see. Yeah, I see. All right, no problem. All right, so let's get into it. There are different theories of depression. So there are psychodynamic theories which focus on real or symbolic loss of a love object. It could be feelings of loss of a relationship with a parent, caregiver, rejection, things of that nature. It does not have to be a real loss. It could be a symbolic loss, which means in your mind you feel disconnected. There is an attachment theory. This comes from the work of Bowlby, which means that we expect there to be healthy, secure attachment with a caregiver and a child. And what happens with depression is there's some kind of disruptance or insecure attachment, which predisposes depression. From a behavioral point of view, there's lack of reinforcement going on. There's lack of connecting a behavior with a consequence going on. There might be some skill deficits going on. So from a behavioral point of view, we target those areas. So let's talk about a cognitive theory, right? So from a cognitive theory, there are what people are called depressogenic, right? So there are certain people who are more depression prone than others. And what we see, according to Aaron Beck, is that there is a cognitive triad, right? A cognitive triad is basically the three features that predispose depression. So people who are more depression prone tend to make internal attributions. It's me versus it's something outside of myself. They tend to have stable attributions. It's never going to change. And they tend to globalize their attributions. It's always going to be this way in every way. Right. So in every way. So all of a sudden, if you have a negative experience where you're saying, I'm a failure, I'm always going to be a failure, and I'm going to be a failure in everything, well, that's going to predispose you for a depression. Right. So that's kind of the cognitive triad part. Now, he added, in addition to the cognitive triad, the idea of automatic thoughts. Now, automatic thoughts are kind of knee-jerk thoughts. We don't consciously think them, but it's our default. We default to these thoughts. So if a person's knee-jerk thought is negative or self-critical, that is going to predispose depression. And then if you have a more negative worldview, a schemata or a schema is a worldview. So your general worldview is more negative. From a cognitive point of view, that's going to predispose you for depression. So we talked about psychodynamic, we talked about attachment theory, we talked about behavior, we talked about cognitive theories. Now, there are other theories out there, self-control theories, so that basically views depression as being linked to feeling like you have no control over achieving your long-term goals, right? So if you feel that there's no way of achieving your long-term goals, then you feel more helpless or out of control, and that's going to predispose you for depression. Interpersonal theory suggests it's some kind of relationship problem. So depression is caused by disruptance in relationships. Now, these relationship problems can be familial. They can be they could be friendship relationships. They could be romantic relationships. So the person struggles in relationships, or there's some kind of breach in the relationship that causes depression. From a neurobiological model, we look at genetic vulnerabilities or predispositions, and then we look at brain structures, physiology, and chemistry, and that are some of our ways of trying to understand depression. From a socio-cultural, socio-environmental perspective, the argument is what happens in your environment is going to predispose you for depression. So living in a more stressful environment, experiencing stressful life events, these kind of things are going to set you up for depression. So let's look at genetic or familial risk. Heritability estimates range between 0.35 to 0.75 in terms of a correlation. That's moderate to strong correlation between genetics and family relationships. Now, I will tell you the reason why it ranges between 0.35 and 0.75 is the more genetic similarity you have, the more environmental similarity you have, the higher that correlation is going to be. So if we can control for both environmental differences and genetic differences, you're going to have a higher correlation. So the more dissimilar your genetics are, or the more dissimilar your environmental experience was, the lower the correlation becomes. But there is a vulnerability. There is a predisposition for depression. Now, from a neurobiological influence, we talk about the amygdala and the hippocampus. When we think about the amygdala and the hippocampus, the amygdala is responsible for fear and rage, so strong emotion states. The hippocampus is memory. One of the interesting findings related to the hippocampus and depression is that depressed people tend to access more negative memories than their counterparts. We talked about the HPA axis already. We talked about sleep problems. We didn't talk about growth hormone and the fact that growth hormone can be a predictor. And then obviously our monoamines, serotonin, norepinephrine, and dopamine. Now, if we were going to pick a neurotransmitter as our primary neurotransmitter for depression, serotonin is the primary neurotransmitter. Even those people have theories of a switch theory, which says that serotonin and norepinephrine are working together. Serotonin sets the stage. It's the first switch to be pressed, so to speak. Now, family influences, we talk about families that have conflict, fighting, use control tactics, authoritarian, have poor communication styles. All of these factors are going to be linked to depression. And then we talked about environmental triggers. Now, emotion regulation. We are not necessarily wired at birth to regulate our emotions, but we start to develop some basic emotion regulation around the age of 3, and it gets better and better. But what we find is that emotion regulation or emotional development tends to be stunted or delayed when it comes to people with depression. So it's interesting. Being able to regulate emotional states is an important factor here. Now, we also see ways of avoidance strategies rather than problem solving or coping strategies to deal with distress. So the best way to deal with distress is to avoid whatever is causing the stress rather than addressing the underlying issue or using coping strategies. Now, one of the things that I do when I do a clinical intake is I ask all of my clients 2 very important questions. What are some of your hobbies? And what are some of the things you do for coping? Now, you might think that these are the same questions, but they're not, right? When you talk about hobbies, you're looking at what a person does for fun or recreation. It may or may not be related to coping. When we talk about coping strategies, where we are specifically targeting when you're feeling upset, when you're feeling depressed, when you're feeling anxious, what are the things that works for you to help you regulate? So we hear things like, oh, I do deep breathing, oh, I listen to music, oh, I go for a walk, I take a hot shower, I exercise, right? All of these things are coping strategies, and they're all adaptive, by the way. And being able to give a person coping strategies when they don't necessarily have them is a tremendous resource in helping people deal with depression. Teaching them that, hey, you don't have to retreat. You can address the problem specifically, or if you want to self-regulate, here are some things you can do. All right. So here's your model, right? If you were looking for a developmental framework, what do you notice about this model? There is one very, very important thing about this model.
Emotion regulation is in the middle, so it seems to be like the biggest factor in there.
Okay, I mean that's a good observation, that emotion regulation or dysregulation is at the heart of mood disorders like depression. Fair. Savannah.
There are certain parts of it that are not connected. I feel like in a lot of the frameworks we look at, everything is interconnected in a way. And if you're, I'm looking at genetic, neurobiological processes and temperament, that is not connected to core beliefs about self and others. And there's a couple others like that.
Yeah, good observation as well. And I was going to make the observation of the opposite point as well, and it's not in contradiction. But if you look at these arrows, there are a lot of bidirectional arrows. So even though the slide says that these are causes for depression, from a very technical point of view, a cause must always precede the effect, right? So when we're talking about from research, really what we're saying is there are risk factors, and sometimes I'll take the one core beliefs and interpersonal competence. Interpersonal competence could impact your core beliefs, but your core beliefs could also impact interpersonal competence, if that makes sense. So it's bi-directional. It's not okay, if we work on the core beliefs in isolation, your interpersonal competence is going to get better. No, there are a lot of factors. So you may recall in my first lecture, I asked you, what do you think causes depression? And I said it's a setup question because there are several dozen risk factors for depression. And I could go through every person in the class and ask for a separate risk factor, and you could identify, right? So it's very, very important to know. So it's not, oh, this is the cause. No, these are risk factors. And I'll even go to the genetic predisposition. Just because you have a genetic predisposition doesn't necessarily mean you're going to manifest with depression. It's just predisposing you to depression. Now, I see in the question, the chat says, does this make depression harder to diagnose or harder to treat? The answer is no, because we treat the symptoms. We don't treat labels, we treat the symptoms. So whatever the symptoms you're showing, which are your unique features of depression, that's what we target. So it does, the framework is just trying to understand where it might come from, right? So, but it doesn't necessarily impact how we treat it, right? We treat symptoms, not labels. All right. So, in terms of treatment of depressive disorders, we talk about cognitive therapy as an intervention. Now, cognition refers to thoughts, right? So we're going to work on cognitive restructuring, which is to take maladaptive thoughts and then rework them to healthier thoughts. So we might help our kids or adolescents identify what are some of the negative thoughts or negative attributions they might have, and then might invite them to say, is there another way of viewing this? Is there another interpretation? And then once we get them to think of another interpretation, we ask them to reassess the original belief, the original thought, and whether their adherence to that original thought has gone up or down. And more often than not, with cognitive restructuring, these negative thoughts tend to go down, right? So we also ask to do self-monitoring, identify when you're being more self-critical, when you have more negative thought basis, and so forth, right? So cognitive therapy is powerful because we're basically teaching you how to rework your thoughts. More often than not, cognitive therapy or cognitive behavioral therapy, if you combine the two, is short term and it tends to be more solution focused. We also target perfectionism and failure to self reinforce, right? So if you did something good, you should take a bow or reward yourself for, working hard to whatever it was that you were struggling with. So behavioral interventions, we focus specifically on the behavior. We focus specifically on the contingency. So if we look at depression, one of our biggest observations is that people stop doing activities that once they derive pleasure from. So with a behavioral intervention, we use what's called behavioral activation, which is we target a behavior that they used to do, they used to like doing, and we encourage them to go back to doing that activity and reinforce or reward themselves for doing that activity as well. Now, CBT or cognitive behavioral therapy is when you combine the strategies of cognitive therapy and behavioral therapy, and it usually has some of the greatest success rates of CBT. Now, medication, there are a whole host of medications on the market for depression, but the only FDA approved medication for children with depression is fluoxetine or Prozac. Now, so Prozac is an SSRI that should not shock you, right? But so yeah, we use things like Prozac. If it's the only FDA approved medication for childhood depression, does that mean that's the only medication that children are put on for depression? The answer is no, right? There are off-label usages, but if you're trying to prescribe appropriately for children, you're going to start with Prozac. And then obviously, if we're going to address the underlying issues, we can take a preventative strategy which reduces the risk of developing depression altogether. So I'm going to stop the recording here, and I'm going to give you your break because I want to have the recordings self-contained. And we'll pick up in 10 minutes.